Hello everyone, welcome back. Today I'll be covering septic arthritis knee in adult, a part 1 video. We started off as an introduction, epidemiology, pathophysiology, A. Hematogenous inoculation, B. Direct inoculation, C. Contiguous spread from adjacent source of infection, and D. Iatrogenic inoculation. Differential diagnosis of septic arthritis, including infective and non-infective cause. The diagnosis, especially joint aspiration, and summary. I hope it helps. Now let's get started. As an introduction, septic arthritis is defined as a joint infection caused by a pathogenic inoculation via direct or hematogenous routes. Acute bacterial septic arthritis is an orthopedic emergency requiring prompt diagnosis and treatment because of the potential for morbidity and mortality. The diagnosis can be challenging as warm and painful knee can be due to other infectious cause and non-infectious cause. Example, osteoarthritis, crystalline arthropathy, systemic inflammatory disorder. The mainstay of treatment is timely joint irrigation and debridement followed by a targeted course of antibiotic. Epidemiology. Patients with history of prosthetic joint replacement, rheumatoid arthritis, systemic lupus erythematosus, crystalline arthropathy, diabetes mellitus, and use of immunosuppressive medications are at increased risk for developing septic arthritis. Staphylococcus aureus is the organism most commonly responsible for septic arthritis, followed by other gram-positive organisms, notably streptococcal species. Certain populations has increased susceptibility for unusual organisms. These include patients with a history of intravenous drug user in which atypical bacteria and fungal infection should be considered. Regarding pathophysiology, acute septic arthritis of the knee can develop by the following mechanism. A. Hematogenous inoculation, B. Direct inoculation, C. Contiguous spread from adjacent source of infection, and D. Iatrogenic inoculation. A. Hematogenous inoculation. Most common mechanism occurs when bacteria and bacteria-laden phagocytes lodge in the synovial membrane. The vessels of the synovial intima lack a basement membrane, and the dense vascularity of synovial membrane allow for the passage of phagocytes loaded with bacteria into the synovium in states of bacteremia. This figure shows the routes of infection. The microorganisms is circled. The route of infection is 1. By hematogenous spread, 2. Adjacent infected tissue, 3. From infected bone, example osteomyelitis, 4. Due to penetrating trauma, 5. During diagnostic procedure, iatrogenic inoculation. The role for synovial lymphatic system in the pathogenesis of septic arthritis. The lymphatic system represents a highly regulated and permeable monolayer of cells. During periods of inflammation, the primary processes of lymphagenesis coordinate immune cell migration. The increased flow of cells and macromolecules through this system may lead to leakage into the interstitium, resulting in joint effusion and elevated pressures observed in septic arthritis. Persistent inflammation may result in damage to the lymph vessels, reduced permeability, lymph node collapse, and ultimately severe synovitis and joint effusion. This figure shows the area of lymphatic network at the joint region that contribute to infection. You can see the initial lymphatic network, and there is a valve collecting lymphatic vessels and goes to the lymph node and to the right lymphatic duct or the thoracic duct. B. Direct inoculation. Once bacteria enter and adhere to the joint, the synovial milieu acts as an ideal culture medium for the bacteria. Direct inoculation of the knee is seen in the setting of a traumatic or iatrogenic knee penetration. Iatrogenic inoculation can occur following arthrocentesis, intra-articular injections, and arthroscopic procedures. Gerson et al. Reported a septic arthritis frequency of 0.1% after arthroscopy. Example during anterior cruciate ligament is ACL reconstruction and 0.037% after arthrocentesis. Again, this figure shows the routes of infection. Infection of the synovial membrane results in hyperemia and recruitment of immune cells, which in turn release a number of pro-inflammatory factors into the joint space. This leads to redness, warmth, swelling, and pain. As the immune response continues, the synovial cells begin to secrete proteolytic enzymes. Cartilage damage starts to occur as early as 8 hours after infection. As this destructive process proceeds, proteoglycans are broken down by day 5 and collagen is degraded by day 9 after inoculation. After the infection progresses, the intra-articular pressure rises, resulting in compression and thrombosis of the synovial vasculature and further destruction of the articular cartilage. This figure shows the inflammatory damage that occurs during septic arthritis infection. In an infection caused by Staph aureus, there is an increased secretion of cytokines, upregulation of TLR expression and pathway. There's an influx of polymorphonuclears, activation of macrophage. There is a heavy influx of B cells and T cells. This will induce the host metalloprotease, MMPs. So this metalloprotease will degrade the joint, and also the complement activation can cause more harm to the joint surface, and this will finally cause damage to the joint vasculature, articular cartilage, permanent cartilage erosion. Regarding clinical presentation, typical signs and symptoms include a hot, swollen, and tender knee with limited and severely painful active and passive motion on examination. The knee of patients with septic arthritis are held in 30 degrees of flexion with external rotation. In contrast, patients with prepatellar septic bursitis are able to obtain more than 90 degrees of flexion. but the extension is limited. Symptoms can present for 2 weeks by the time of presentation to the doctor. The risk factors: age more than 60 years old, recent bacteremia from recent upper respiratory tract infection, dental procedures, genital trauma. In diabetes patient, malignancy requiring chemotherapy or immunosuppressive therapy in the past 6 months, liver cirrhosis patient, renal disease patient, drug or alcohol abuse, long-term corticosteroid therapy, example asthmatic patient, chronic obstructive pulmonary disease, injury or surgical procedure involving the joint. In patients with rheumatoid arthritis, it has 4 to 15 times risk than in the general population. This increased risk is related to the disease process itself, as well as the immunosuppressive therapies used to treat it. In particular, comorbidities with immunomodulation or those requiring immunomodulating treatment. The differential diagnosis of septic arthritis knee include infectious as well as non-infectious illnesses. Other causes of infection include septic bursitis and alternate infectious causes of arthritis. These include septic bursitis, gonococcal arthritis, Lyme disease, tuberculous arthritis, viral cause of arthritis, fungal arthritis. The non-infectious cause of arthritis include trauma and inflammatory arthritis. These include acute traumatic arthritis, bloody synovial fluid or hematosis, crystal-induced arthritis, either gout or pseudogout, reactive arthritis or spondyloarthritis, example in patient who has ankylosing spondylitis, avascular necrosis patient, rheumatoid arthritis patient. Diagnosis: initial evaluation with history, physical examination, imaging, and laboratory studies including blood culture. The gold standard is joint aspiration with synovial fluid analysis. This picture or image is very important. For normal, usually the color is transparent with high viscosity, negative gram staining and bacterial culture, whereby the leukocyte count is less than 0.2 times 10 power of 9 per liter and less than 25% of leukocyte. The crystal is negative. For non-inflammatory, will be transparent with high viscosity. The difference between normal is the leukocyte count. Is around 0.2 to 2. For rheumatoid arthritis, either translucent or purulent with low viscosity, but the culture will be negative. The leukocyte count around 2 to 10 times power of 9 per liter and more neutrophils. For gout or pseudogout, the main difference is there is a positive crystal during aspiration. For septic arthritis, is purulent in color, variable viscosity with positive gram staining and bacterial culture. More than 50 times more than 50 times the power 10 power of 9 per liter of leukocyte count, and more than 75 neutrophil. For hemorrhagic, the difference is totally the color. It's bloody in nature. The gram stain and bacterial culture might be positive. Please remember, in part 2 video, I will concentrate more regarding the management of septic arthritis in adult, regarding the operative management, antibiotic duration, etc. So stay tuned. In summary, acute bacterial septic arthritis of the knee is an orthopedic emergency, and if left untreated, can result in joint degradation. Important risk factors for development of septic arthritis include age more than 60 years old, recent bacteremia, diabetes, cancer patient, liver cirrhosis, renal disease, drug or alcohol abuse, a history of corticosteroid injection, a recent history or surgical procedure, a prosthetic joint, and a history of rheumatoid arthritis. The diagnosis is primarily on history and clinical presentation of a red, warm, swollen, and painful joint with limited range of movement. Laboratory values and inflammatory markers from serum and joint fluid may serve as adjuncts when there is clinical suspicion of septic arthritis. The initial and general antibiotic regimen should cover Staphylococcus aureus and methicillin-resistant Staphylococcus aureus and gram-negative organism. The antibiotic regimen should be specified following the culture results of the infected joint. Operative management involves either arthrotomy or arthroscopy of the knee with thorough irrigation and debridement of all infected tissue. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.